So how many of you are currently doing first trimester fetal cardiac screening? How many would like to do first trimester fetal cardiac screening? How many don't care whether you do it or not? Okay, so I shared with you this. So let me talk a little bit about cardiac embryogenesis. Just briefly to show you and highlight here the early development of the fetal heart going from a tube and the folds that exist to create the current structure, and the importance of this slide in that the heart doesn't complete its development, especially with the atria and ventricular septa that actually close towards the end, until about 9 to 10 days of estimated gestational weeks. So you have to be really careful about doing any cardiac imaging, looking for malformations before 10 weeks of gestation, because embryogenesis may not be fully completed by that time. This is a clip of the 4-chamber view at 9 weeks. The apex of the heart here is mine. This is a dated clip, so I've had this for a while. But you can see it's hard to see any details. Maybe with our improved equipment, we can do better. But I wanted to show you how important is adding color Doppler to the first trimester cardiac imaging. This is the same fetus with the same clip, now with color Doppler. You could see that there are 2 ventricles. You could see the septum in between, and you could see the atria, and you could see the descending aorta on the left side. So you're going to see throughout this presentation that color Doppler is so essential for the evaluation of the fetal heart in the first trimester. So what do we know today? We know that cardiac screening in the first trimester has high detection rates. We know that the use of color Doppler is essential to your ability to look at the fetal heart in the first trimester. We know that including the outflow tracts in some way or another, whether you're looking at LVOT, RVOT, or the 3-vessel trachea view, improves your detection. And we know that having an on-site protocol at your laboratory, at your ultrasound unit, is highly beneficial. It has been shown repeatedly to improve your detection rate. So if you take anything with you, just go home and create a protocol for cardiac screening in the first trimester. I'm going to share with you some recommendations here and start training your sonographers and physicians toward that. We also know that nuchal translucency, tricuspid regurg, ductus venosus, and cardiac access are decent screening modalities for congenital heart disease in the first trimester. So screening for congenital heart disease in the first trimester, the nuchal translucency has a sensitivity somewhere between 21 and 36% based on what threshold you use for screening for congenital heart disease. We know that an abnormal ductus venosus with reversed A wave has close to 27%, and this is based on a large data from Kipros's team. We know that tricuspid regurg has close to 29% detection rate for congenital heart disease in the first trimester. And any one of those, if you use an NT greater or equal to 95% plus any one of the others, they're present in 55% of fetuses with major congenital heart disease. And if you use a threshold of 99%, that's present in 46% of fetuses with congenital heart disease. We also know, based on data from our lab in a multi-center international study, that cardiac access is a very powerful marker for congenital heart disease screening in the first trimester, somewhere between 70 and 75%. And this is the study that Elena was the first author on, looking at 394 normal fetuses matched 2-to-1 with 197 controls, cases with congenital heart disease, using a normal cardiac axis of 30 to 60 degrees. And you can see in an autopsy specimen at 9 weeks that the heart actually assumes that normal position in the chest quite early in embryogenesis. You see that the red dots are the cases and the blue dots are controls. Message here is that cardiac access does not change in that gestational age window and actually stays the same into the second trimester. And you can clearly see the abnormal cardiac access with more levo rotation or deviations towards the left side of the chest in the presence of congenital heart disease, with the detection rate of about 74%. And if you look at the data from the study, looking at the nuchal translucency in this cohort, whether you use greater than the 95th or just a cutoff of 3.5 millimeters, you can see that the cardiac access performs better in those cases without associated fetal karyotypic abnormalities. So remember that the cardiac access is a really important marker in the first trimester. And as you look at the four-chamber view, it's important for you to subjectively assess whether the cardiac access is normal or abnormal. This is a large meta-analysis of 63 studies that showed that in the non-high-risk population, the sensitivity of the cardiac screening in the first trimester is 55% and is 67% in the high-risk population. These are very good numbers. They are not that far from what we do today in the second trimester. So keep that in mind. So anybody that argues that the first trimester is not a good time to detect fetal malformations, whether you're talking about cardiac or extracardiac, there's abundance of data now to support that. From the same study, if you look at using a combination of four-chamber view, outflow tracks, plus color flow Doppler, your detection rate now goes up to 80%. This is all cardiac malformations. And if you do not have a protocol at your site, your detection rate is really low. So again, the important message here is having an anatomical protocol is essential in your ability to make sure everybody's compliant and everybody's to improve your detection of congenital heart disease. So what do we detect? We detect more than 60% of abnormalities that are related to the four chambers, such as hypoplastic left and right heart and so forth. We detect about 25 to 60% of the conotruncal abnormalities, and we miss the majorities of VSDs and other rare abnormalities, as you see here. What is really critical to know is that this ultrasound is all about image optimization. And the traditional steps of improving your image using on grayscale, make sure that you narrow the sector width, reduce your depth, magnify, make sure your angle of insonation is appropriately guided to what you want to look at, substantially improve your detection. I'll give you some tips here that typically a full bladder makes your life much more difficult in looking at the fetus in the first trimester because you limit space. The bladder compresses the lower segment, and the fetus typically is in a transverse orientation in the fundus. So emptying the bladder is really important. Asking the patient to cough 2 or 3 times would allow the fetus to move. So if the fetus spine is up, typically that results in a somersault for the fetus, and you're able to access. And putting a gentle pressure on the uterus really results in fetal movement. So these are all small tricks you could use in your scanning in the unit. Optimizing grayscale first, then coming and optimizing color Doppler is really important. Here we use mid-velocity ranges, not the traditional velocities that you use in the second and third trimester. Looking at the heart, you need to be in about the 20 to 25 centimeter range. Filters should be a little bit, again, mid-filters, and make sure we like to use the bidirectional Doppler, the power Doppler. We feel this is a better use in this first trimester than traditional. Again, here's the same fetus with conventional color Doppler and with high definition or power Doppler. We feel that fills the ventricles better and provide more depiction of the atria and ventricle in the first trimester. Certainly, a lot of the high-end systems today have additional algorithm that adjusts the display of color. This is called LumiFlow, Radiant Flow, in many manufacturers, but it's highly, highly useful in the first trimester. it's really a great tool to add. Even though this is just a post-processing tool, you're not doing anything to the blood flow, but the visualization is so optimized for use in the first trimester, as you see here. The common question I get, should I use a transvaginal or transabdominal approach? Most of the studies are done transabdominally, and I would say probably 90 to 95% of the studies that we do are transabdominally. Transvaginal will give you have a high resolution probe, you're closer to the fetal heart, but then it's inconvenient, it delays you, you have to clean the equipment afterwards, and requires some expertise. We're not used to move the probe in the direction that we need to image the heart. I think that transvaginal is most optimal at less than 13 weeks. Beyond that, the fetus could be outside of the range of your probe, and typically if the fetus is in a transverse lie. And if you look at the studies that I shared with you and others, most of the studies are done transabdominally, and we recommend that you start transabdominally and then resort to the transvaginal ultrasound if one, you suspect there's a malformation, or two, you feel that the fetus is in the right orientation and you can't get what you want to abdominally. So if the baby is in a transverse lie, getting the transvaginal probe very close to the chest would give you superb imaging, looking at the fetal heart. When is the best time to do this? You could see this is data on all malformations in the first trimester, not only cardiac. You see, as you move in gestation from 11, 12, 13, 14, your detection rate of congenital heart disease increases, but starts to plateau somewhere between 13 and 14 weeks. So somewhere between 12 and a half to 13 and a half probably is an optimal time to do the first trimester ultrasound. When you have the opportunity to schedule a patient for a first trimester ultrasound, we target around 13 weeks. We're still in the first trimester, the fetus is large enough for us to be able to see detailed anatomy. So what should we look for? The first plane that I recommend is looking at the abdominal situs and using color Doppler. First, you're looking where the stomach is, right? So you're determining situs on the fetus. But also, I'm adding color here to look at the descending aorta and the IVC. So I want to see an IVC that is on the right side. I want to see a descending aorta that is on the left side. And if you're right here and you want to do a ductal venosus, spectral Doppler, you can do that. In this plane, or the sagittal plane is actually preferred for that. Next is the four-chamber view. If you look in different fetuses at 9, 10, 11, 12, 13, 14 weeks, you see that from 12 weeks onward, the four-chamber view has all the anatomic characteristics that you're used to seeing in the second trimester. The moderator band, the offsetting of the valves on the right side, all the things that you learned in the second trimester are present from 12 weeks onward. Now, color Doppler is really helpful, especially if the fetus is not in an optimal position. Here at 11 weeks, here's the grayscale. I can probably guess that the apex of the heart is here, the spine is here, so that's a normal cardiac axis. But look at the advantages of color Doppler. Here I see that there are two ventricles that are equal in size. There are two atria that are equal in size, descending aorta on the left side, and there's normal cardiac access. All this in a simple four-chamber view with color. Look how magnified the fetus is and how magnified the heart is. This is at 13 weeks. If I show you this and I say this is at 18 weeks, you would not be able to tell the difference, right? So ventricles look normal, left ventricle apex forming, moderator band in the right, ventricular septum, normal cardiac axis, descending aorta on the left side, and so forth. Again, here's at 13 weeks with and without color. Now, looking at the pulmonary veins, to see the pulmonary veins, you follow the same plan that we showed you yesterday on the scanning, on the live scanning. You have to reduce your color velocity here, probably 5 to 10 centimeters per second. You increase your color gain. Look how increased the gain is. Reduce your color filters and adjust your angle of insonation so you're coming parallel to the direction of the pulmonary veins, as you see right here. Here's another example using the newer technology, the slow flow and things like that, like you saw yesterday, both on the GE and the Samsung systems. You see, I'm seeing the 4 pulmonary veins right here. I'm not interested to see the flow within the heart anymore. I'm really more focused on the pulmonary vein. I'll venture to say that once you do this 2 or 3 times, that imaging the pulmonary veins may be easier in the first trimester than it is in the second trimester, because you don't have any shadowing from the ribs and the bones around, and using this approach would almost always highlight the pulmonary veins coming to the left atrium. Now looking at the outflow tract, LVOT, RVOT here, and the 3-vessel trachea view. The LVOT, this is at 13 weeks. Here's the LVOT showing the angle we talked about yesterday on color Doppler. This is difficult to obtain, and this is a very thin slice that I think you will struggle to get even as you build expertise into this. I don't think this is necessary for cardiac screening in the first trimester, because interpretation could be challenging if you're looking for the presence of divisions coming out of that LVOT, whether there's override in that view or not. I think the same applies for the RVOT right here. What I strongly recommend to focus your imaging is on the 3-vessel trachea view. The 3-vessel trachea view is very easy to get in the first trimester. You go from the 4-chamber view, you slide up in the chest without any orientation of your probe. And as you can see right here, you go from the 4-chamber view to the 3-vessel trachea view. And here's a 3D rendering showing, again, the aorta and the pulmonary artery coming together into the 3-vessel trachea view. This is a very powerful view in the first trimester, easy to obtain, and has a lot of value in screening for congenital heart disease. This is a study looking at unselected population. When you combine the 3-vessel trachea view with the 4-chamber view, detection rate of close to 76% of congenital heart disease. What about the sagittal views? I don't think they're essential in the first trimester because they are so close to each other. So you typically get the ductal and the aortic arch together, but I don't think they add to cardiac screening beyond the 3-vessel trachea view. Remember, we're not doing a fetal echo in the first trimester. We're only doing cardiac screening for the suspicion of congenital heart disease. So I would suggest the abdominal circumference with and without color, 4-chamber view with color, and 3-vessel trachea view with color for your screening for congenital heart disease in the first trimester. So let me show you what you can detect now. Here's hypoplastic left heart syndrome. So what are you seeing? Here's no left ventricle. This is at 13 weeks. Blood flow shows flow across the tricuspid valve only, no flow across the mitral valve. 3-vessel trachea view shows you what? The pulmonary artery with forward flow, the aorta with reverse flow. Exactly what we see in the second trimester. Here's another case right here. I put the annotations where the left ventricle is. Look how abnormal this 4-chamber view is. Color Doppler, no flow across the mitral valve. There's only a single channel bringing blood to the right ventricle through the tricuspid valve. And again, the pulmonary artery coming in. The aorta is very tiny here, showing you some yellowish coloration. That's the reverse flow in the aorta at that level. Now, we also see the critical aortic stenosis that shows in a hyperechoic left ventricle, as you see right here at 14 weeks, with color flow right across the tricuspid valve. Here's another example. There's a little bit of pleural fluid here. Look at the size of this left ventricle. Look at the bowing in the septum already, the echogenicity, and blood flow has flow right across the tricuspid valve, no flow across the mitral valve. So a dilated left ventricle, hyperechoic left ventricle, and color Doppler confirms that. Coarctation of the aorta at 14 weeks, the same features that we see in the second trimester. This proportion between the ventricles that you see on color Doppler here on your left, and a small aortic isthmus on 3-vessel trachea view on the right. Atrioventricular septal defect is probably one of the more common anomalies that are diagnosed because a lot of those patients come in referred with abnormal NIPT with trisomy 21, suspected trisomy 21 on that. The important features here is the H sign. What is the H sign? Is blood flow coming in centrally and dividing over the septum, as you see right here. And again, regurgitations that you see in this dysplastic valve in the middle of the heart. So the common channel coming in, and any regurgitations that you see, especially if it's centrally located, should be highly suspicious for the presence of atrioventricular septal defect. Here, the apex of the heart is below. Look at the red bringing blood in a central channel, and look at the blue regurgitant outside. And here's Here's the flow, and here's the regurgitation out, as you see. So that's really important features in the diagnosis of AVSD. So look at the regurgitant jet. If it's centrally located, you should be suspicious for the presence of this abnormality. Epstein anomaly is hard to diagnose. It's rare to diagnose in the first trimester, I must say. But again, the same features. What you see is a slightly dilated right atrium. Is not as dilated as you see in the second trimester. And then color Doppler is key. Look where this regurgitant jet starts, deep within the right ventricle coming up. This is exactly the feature that we see in Epstein anomaly in the second trimester. And again, you have a holosystolic tricuspid regurgitation. And because of this lesion is right-sided, typically it's associated with reverse flow in the ductus venosus. Here's another case of Epstein at 15 weeks. Now you're starting to see right atrial dilation here. And if you put color Doppler, you see that this regurgitant jet starts deep within the right ventricle. Again, look at the optimization of the image, magnification, making sure that your color box is as small as possible. Here's at 13 weeks, another case of Epstein with the same finding. Case of tricuspid atresia with VSD, the same features, flow across the mitral valve. There's tricuspid atresia, no flow here. Blood flow reaches the right ventricle through the ventricular septal defect, associated pulmonary stenosis, as you see here. Single ventricle, double inlet, single ventricle, as you see in this case. Heterotaxy. This is easy to diagnose in the first trimester. As you try to establish situs, the stomach is on one side and the apex of the heart is on the other side. Here's another cases with significant cardiac abnormalities. As you see, the cardiac axis is severely abnormal. We don't look for VSDs. This is a case looking for other things, and there's a small muscular VSD in here. A lot of those tend to close on their own by the second or early third trimester. How about the great vessels? So clues to diagnosis for tetralogy of Fallot. The same cardiac axis is important, left axis deviation as you see right here. And then the traditional Y sign for the aortic override that you see. That is also key to the presence of aortic override, in addition to aliasing as we've discussed. And then 3-vessel trachea view abnormal with a small pulmonary artery. So the same features, if you look at this case, for instance, significant cardiac axis deviation here. Then you add color Doppler. You see a large vessel that's overriding with some aliasing blue here. That's aortic override. And I pulled from this clip this still image to show you that. And then you look at the 3-vessel trachea view, and the pulmonary artery is very, very tiny with reversal of flow in red right here. So this is a case of tetralogy of Fallot with pulmonary atresia with VSD. So this is how we can arrive to the diagnosis of these cases as we go by. Common arterial trunk, look at the significant axis deviation here at 14 weeks, large defect right here. Again, mostly this overriding aorta is coming from the right side, but look at the aliasing in here. And then at the level of the 3-vessel trachea view, there's a large vessel that's giving off branches right here, the pulmonary branches, as you see. Same in a different fetus right here, with a common arterial trunk at 14 weeks. Critical 3-vessel trachea view image to remember: a single vessel that is normal in size is associated with transposition of the great arteries. And what we've discussed before, so this is how you make the diagnosis, or you suspect the diagnosis. There is a single vessel of normal size that you see. And you go to look at these to confirm, but typically you're looking at the aorta at the level of the 3-vessel trachea view, and that's why you have a single vessel, because the pulmonary artery is right under it. And I showed you a case in the second trimester yesterday to display that. Sometimes there's a convex shape to the single vessel, as you see right here. Other times it's straight. It's called the I sign. Diaphragmatic hernias, again, easy to detect if you look at that. Aberrant right subclavian artery is important to look for, to learn how to see those. You have to reduce your velocity scale because you're looking for a very low velocity flow in here and be parallel to the direction of flow. The importance of this in patients at increased risk for chromosomal abnormalities I think seeing an aberrant right subclavian artery could be important in counseling those patients. Patients that have low risk, we usually don't make any deal out of this, and we call it a normal variant. Likelihood ratio is somewhere between 3 to 4. Again, high-risk patients, this becomes important. Aortic arch, same deal, right aortic arch right here. Again, in a fetus at 12 weeks. The ductal arch on the left side, aorta on the right. You see the brachiocephalic vein on top. And the 3-vessel trachea view is important. You see in hypoplastic left heart with reverse flow, tetralogy with a small PA, transposition with a single vessel, right aortic arch, and aberrant right subclavian artery. So the spectrum of congenital heart disease that you see in the first trimester is more complex than what you see in the second trimester, because there's a higher association with aneuploidy, and some of these fetuses don't make it into the second trimester ultrasound. And there's a higher association with high drops. If you look at the existing guidelines for fetal cardiac screening, the ESWA guidelines were released just recently this year, and the AIUM on their website, open access, has a detailed diagnostic OB ultrasound. I strongly recommend you download this and start looking into that. Here's are the planes that, between the two, they've a lot of concordance on this. They suggest an abdominal circumference view, 4-chamber view with and without color, and 3-vessel trachea view. I will add to those color Doppler at this level because I want to see the IVC and the descending aorta. That would be my suggestion to do so. And then look at the cardiac access subjectively. In addition to that, if the cardiac access is abnormal, I think you need to investigate further. So my recommendations, it is easier than you think. Optimize your grayscale and color Doppler. That is critical for your ability to do so. You know all the anatomy, and the anatomy is the same. You just have to learn to look at it under the microscope, if you will. Color Doppler is essential for diagnosis. You cannot look at the heart in the first trimester. For that matter, in the second trimester, I would say, without color Doppler. Develop a protocol for your unit. There are many that are available outside. And nuchal transduced TR and ductus venosus, and especially cardiac access, increasing your detection rate. And most cardiac malformations has the similar features as they have in the second trimester. So your knowledge of what to look for could be applied into the first trimester. Again, for those of you who were not here yesterday, I want to put in another plug for our fellowship in fetal cardiology. Must have completed an MFM fellowship. It's a 1-year fellowship. Elena is the program director, and if you are interested, email me or email Dr. Sinkoskaya. Thank you very much for your attention.